All right, so we'll get started. Good morning, everyone. My name is Dr. Madeline Verhovsek. I'm the Chief of Medicine here at St. Joe's, and welcome to Citywide Grand Rounds for November 23rd, 2023. Next slide, please. So we will start with a land acknowledgement today. Today and every day, we acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations, and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and Haudenosaunee that bound them to share the territory and to protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. Next slide, please. And this morning, it is my extreme pleasure to welcome back our colleague who's near and dear to many of us, Dr. Deborah Siegal. She is going to be speaking with us on the topic of anemia in hospitalized patients, vampirism, and other tales. So there's some dripping blood on her slide there. Seems kind of ominous, but I don't think there'll be anything scary. A brief further introduction to Dr. Siegal. She is an associate professor of medicine at the University of Ottawa and a scientist at the Ottawa Hospital Research Institute. She holds Master of Science degrees in pharmacology and health research methodology. Her primary interests include management of anticoagulant-related bleeding, restarting anticoagulants after bleeding, perioperative management of anticoagulation for urgent surgery, and ischemic stroke in patients with cancer. Her research is funded by CIHR, CanVector, Heart and Stroke Foundation of Canada, and the American Society of Hematology. She has published over 120 peer-reviewed articles and has an H index of 37, which is just outstanding for any of us who know about these research metrics. So we're really delighted. Dr. Siegal is going to be speaking with us about a whole research endeavor that started here at McMaster, and she's going to take us on the journey, apparently just published in print yesterday. So hot off the press, over to you, Dr. Siegal.
Thank you so much, Dr. Verhovsek. It's such a pleasure to be here. This was actually the first place I really wanted to present this work because it all started at McMaster, over 10 years ago when I was a resident. And I'll talk a little bit about the journey because I think that's one of the really cool parts of this story. And so I really owe the success of the research that I'm going to be telling you about to folks at McMaster. And hopefully I won't forget anyone with the shout outs, but apologies if I do. So I'm going to be talking about anemia in hospitalized patients. I like the term vampirism. I have some disclosures. I've received honoraria, which are paid indirectly to my research institute for mostly educational presentations, which is my own content from some manufacturers of anticoagulants, but that's unrelated to this presentation. Okay, and these are the objectives that I'm hoping to accomplish today. After this presentation, I'm hoping that you'll walk away with the ability to describe the burden of anemia in hospitalized patients. This isn't a big challenge. Of course, I think a lot of us recognize that this is a problem for many people in our hospital. We're going to discuss laboratory testing as a modifiable cause of blood loss, anemia, and red cell transfusion, and then discuss the effect of switching to tubes that collect less blood for lab testing on red blood cell transfusion in the intensive care unit. So I'll start by setting the stage, which is, of course, this isn't a surprise to many of us on the call who work in hospitals or with patients who have chronic conditions. Anemia is really common. Up to half of hospitalized patients have some degree of anemia, and that proportion actually is higher among the hospitalized elderly at about 75%. And interestingly, this problem, anemia, affects half of patients with acute myocardial infarction, and there's a really nice series of studies from the United States about patients with acute coronary syndrome and anemia. Maybe not a population that we would think would be at risk of this complication, but that's what the data show. And among hospitalized patients, those in the intensive care unit or ICU are basically at the highest risk for anemia. You can see here from this slide that the proportion of patients with anemia increases substantially from admission. And then by day 3, over 90% of folks in the intensive care unit have some degree of anemia. And anemia is associated with adverse outcomes, and that's include things like, higher 30-day mortality, longer intensive care unit stay, and longer hospital stays. So here we're seeing both clinically important outcomes and also healthcare resource utilization outcomes that are affected by anemia. And of course, the hematologists on the call, me being one of them, recognize that anemia is, complicated and multifactorial in nature, particularly among folks in the ICU, due to a lot of underlying etiologies, many of which are either not modifiable or difficult to modify. And anemia then, of course, leads to the transfusion of red blood cells, and up to 40 or 50% of people who are in the intensive care unit receive at least one red blood cell transfusion. And interestingly, about half of them are given without evidence of active bleeding. So we're ultimately administering red blood cell transfusions to treat anemia or to correct anemia. And we've already talked about the adverse outcomes associated with anemia, but also transfusion. And I'll touch a bit upon this in a few slides. But just to say that looking at this picture and thinking about the causes of anemia, really one of the things that occurs to us as we work in hospital and ICU is that we do take a lot of blood from patients for laboratory testing, which is important, for their care, but also is a potentially modifiable contributor to anemia and red blood cell transfusion. So we and others, of course, have reasoned that if we can reduce the volume of blood that we take from people for lab testing, can we actually impact anemia and red cell transfusion? So what do we know about blood loss for lab testing in this setting? Well, it is actually rather substantial. So one large observational study, which is now a bit older from the United States, suggests that up to 40 milliliters per day is taken from patients in the intensive care unit. That's like donating a whole unit of blood, if you've been in the ICU for about a week. But unlike healthy donors, of course, people who are in the intensive care unit and have critical illness are unable to compensate for blood loss in the same way that healthy donors might. We did a retrospective chart review of ICUs in Hamilton of over 7,000 patients, and we showed that on the average volume that's drawn for blood loss during the intensive care unit stays about 214 mils, which is about 1 cup. If you can think about your measuring cups. But what's really significant about this is that 90% of the blood that's taken, particularly if you use the larger tubes like this one, is actually discarded as waste in the lab. And only a very small amount of blood is actually used for testing procedures. So here is an opportunity for change. And this is just a really small cohort of healthy volunteer subjects who underwent phlebotomy of about 300 milliliters. And you can see here that there was a drop in hematocrit after phlebotomy. And again, speaking to the point that, there is an effect of taking blood from people, but again, most healthy people can compensate by increasing erythropoiesis from their bone marrow, which is something that people with critical illness or other, conditions for which they're in hospital are unable to do. And we know that diagnostic blood loss, there is some evidence that suggests that diagnostic blood loss or blood loss taken for lab testing actually does worsen anemia. So in that nice series of studies from the United States, patients with myocardial infarction, every 50 milliliters increased the risk of a hemoglobin less than 110 by 15%. So we're seeing these numbers. Now you can see, well, maybe that's not significant, but over time, cumulative increases in blood loss actually can have an impact that's significant. In hospitalized medical patients, in another study, every 100 mils was associated with a drop in hemoglobin of 7 grams per liter. And of course, anemia leads to frequent transfusion in the intensive care unit. Again, we've already discussed that about half of people in the intensive care unit receive at least one red cell transfusion. 75% of those in the ICU for more than 7 days are transfused. So we're talking, a lot of transfusions in the ICU, which is the reason why we targeted this population for our study, but we'll talk about that a bit more later. And again, every 100 mils of blood taken increases the risk of red blood cell transfusion by 2-fold. So I've just told you, that people on average have a cup of blood taken or 250 mils taken, and that every 150 mils increases the risk of red blood cell transfusion 2-fold. So this just summarizes the results of a nice quality improvement study that was done in Toronto is a quality improvement intervention to reduce unnecessary phlebotomy and medical surgical ICU. So this was primarily regarding lab testing and lab test ordering. But what they showed was that after the intervention, they decreased phlebotomy volume from 41 to 34 mils per patient day. there were fewer blood tubes collected per patient day, and actually fewer red blood cell transfusions given, from 10 to 4 transfusions per 100 patient days. So actually the point here is, I think, we can move the needle just by lowering volume of blood taken from people. This is very familiar to many of us. Red blood cell transfusion, it sort of goes without saying, right? Red blood cell transfusion is associated with harms. Of course, that's why we have to obtain consent in order to administer it. And on the left-hand side, you'll see here resource implications. And this is important, particularly in our current context of blood product shortage. There is a limited availability. The direct cost of a red blood cell unit is about $500, but that doesn't include additional costs of testing, preparation, storage, administration, and managing transfusion reactions. There are direct harms that can be experienced by patients or recipients from transfusions themselves, including transfusion reactions, volume overload, lung injury, infection, allosensitization, and allergy. And those are all the things that we tell people, although some are more common than others. And then finally, we do see that red blood cell transfusion is associated with adverse clinical outcomes, including death, longer admissions, infection, organ dysfunction, and prolonged mechanical ventilation in the ICU. So how much blood do we actually use for testing? So this is a slide which was given to me by Dr. Stephen Hill, who I've worked with for over a decade on this issue. And you can see here, of course, that the volumes are very small. So if you have a 4 milliliter tube of blood, 2 mils of that is plasma. And you can see here, on average, 5 to 15 microliters for chemistry tests and 25 to 50 microliters from immunoassays. And these are the ones that actually require the large volume, right? We're still talking on the order of microliters. We're taking 2,000 microliters with each tube. What's also interesting is that there are tubes that automatically collect less blood. So these are so-called vacutainer tubes. They are evacuated inside the tube, and that vacuum actually draws the blood into the tube. And so depending on the amount of volume, they actually fill to a predetermined volume. What we're not talking about, and what sometimes people confuse, is the microtainer tube. So those are the ones on the left here. You can see with the X and the pink cap, these are capillary tubes that are often used in neonates. And these tubes require manual aliquoting, either with a heel poke or with manual aliquoting at the bedside or in the lab. So they're okay sometimes for one-off testing for an individual patient for whom you might deem these to be necessary, but really not scalable for large scale automation in the lab, and even blood draws in the intensive care unit or hospital because of the health and safety concerns with aliquoting. So we call these tubes, the tubes that we're talking about today that fill automatically, are called short draw or soft draw or low vacuum. And so they have less vacuum inside. They automatically fill to a lower predetermined volume. They have the same cost. They have the same physical dimensions on the outside. So they fit on the same equipment, but they're not routinely used in adults. So, I was asked this question many, many times over the years. Why do we not just do this? And I can tell you, when we looked into this, sort of 10 years back, people in the late 80s were calling for a reduction in the volume of tubes that were being used to collect blood. But in fact, there is an evidence gap. We don't have randomized trials. We don't really know what the benefits are. And so we haven't been able to demonstrate a clinical benefit before. And we also don't know what their harms. And there are legitimate concerns about, sampling, testing, and the validity of results. So ensuring that laboratory processes would be unaffected is actually a really important part of the story. And there is also this contribution of a lack of awareness, or perhaps a complacency around making change. I think clinicians are often unaware of the kinds of tubes or how much blood is drawn. Phlebotomists and nurses who draw blood are actually keenly aware of how much blood we take, but perhaps not clinicians. And this is something that maybe we were unable to advocate for. I know there's some complacency, like, well, things are working, we don't want to mess things up, why change? As is with a lot of things in medicine and other areas. So I hope I've set the stage for you that there was a rationale to conduct a clinical trial in this space, also because the clinical trial is done. So, but I think I've established that blood sampling does in fact contribute to anemia and red blood cell transfusion. Here we have an opportunity because 90% of the blood that's collected is discarded as waste. We have the tubes which automatically collect less blood. They're lower volume. They're available from the same manufacturers. They're compatible. They have the same cost. And so really we reasoned that a randomized control trial which focused on a clinical outcome that was important and addressed harms was needed to change practice. So I'm going to spend a few slides just talking about some of the methods, and I think it helps, to understand the results of the study later on. So of course, people may be familiar with this concept, and it's a spectrum. There's we have explanatory and pragmatic trials, and in fact, most studies are some combination of these things. But on the left, you have explanatory trials. These are highly selected patient population, rigid protocols. These are separate from usual care and conducted by special study teams that are concerned primarily with demonstrating efficacy, and they have a high degree of internal validity. So they answer the question, can an intervention work under ideal conditions? On the right-hand side, we have pragmatic trials, and those include a more broad patient population. Oftentimes, and not always, it's a complex intervention applied perhaps in a usual care setting, like a hospital or a clinic or an ICU, for example. They're often interventions that are implemented by a clinical care team, and they're concerned with effectiveness and have more external validity. So they answer the question of, does an intervention work under usual conditions? And so there are a lot of examples of pragmatic trials, and then there's pragmatic, elements of pragmatic trials, and there's actually ways that you can evaluate how pragmatic how pragmatic your trial is. And so I just listed a few here. Cluster trials are one of the trial designs which is used for pragmatic type trials. And so I'm going to focus here today on the stepped wedge trial, which is the type of cluster trial that we did for our Strata study. A cluster trial is a trial in which an intervention is applied at a level of a unit of care. So that could be, and it actually doesn't even have to be a unit of care. It can be, hospital, a clinic, an ICU, an emergency department, a country. A cluster is a group of individuals as opposed to an individual patient randomized trial where individual people receive, intervention A or intervention B. In this type of trial design, a unit of care, a unit of patients, or group of patients receives intervention A or intervention B. And there's different ways that you can do this. The step wedge cluster randomized trial is a type of randomized trial in which there is an introduction of a new policy or a new treatment. So this is actually quite a common design for policy or pathway type interventions where they're sort of complex, like I'd mentioned in the previous slide. In this type of intervention, in this type of study, the intervention is introduced in time steps. So at every step, one or more sites receives the intervention, the policy, the treatment. But the timing of that switch from control to intervention is actually randomized. At the beginning of the trial, everybody's starting out doing what they're doing at baseline. And then by the end of the trial, all the sites have implemented the intervention. So it's also ideal for interventions where you want, low risk interventions with a high likelihood of benefit, where you sort of want people to be able to implement by the end of the study. In this way, you can both test the effects of an intervention on relevant outcomes, and you can also implement a likely effective therapy or policy or treatment in clinical practice. So some advantages are that it's randomized methodology and that each cluster is exposed to the control and the intervention. So each site or cluster has it's almost acts as its own control, which is helpful for statistical efficiency. It provides information for research and for policymakers, and it can improve the speed of translation into practice. There's a whole host of disadvantages, which I'm happy to chat about if we have time at the end, if people have questions about that. So we were thinking, a stepped wedge trial seems like the right type of intervention for the right type of design for this intervention, which was the smaller volume tubes. We had done a lot of stakeholder engagement to understand, the implementation challenges. And in a busy ICU setting, it was deemed infeasible to implement the intervention of small volume blood collection tubes for individual patients in a busy ICU. But before we set out to design and undertake a large randomized controlled trial, we did a pilot study, and we started with a pilot study. This is the Stratus Mixed Methods pilot study. So because we had some data already about the proportion of patients who were transfused in ICUs in Hamilton, we knew how much blood kind of was taken from people. What we really wanted to know was, could we implement lower volume blood collection tubes in an ICU setting. And we wanted to understand feasibility of that. And actually, we learned a lot along the way. So we did this at the Hamilton General Hospital, the CV-ICU. It was about 360 patients, and it was a before-after study. So we had a before study where we collected data for 8 weeks using the standard volume tubes. We did educational sessions for nurses and laboratory staff. And then we had the intervention period, and where we implemented the lower volume blood collection tubes into the CV-ICU. And then we conducted focus groups, again, with end users. So the nurses who were taking the blood and the lab technicians who were processing the samples. And our primary outcome for this study was feasibility, which we defined really as being able to successfully switch to lower volume tubes. Adherence, which is important. There were always questions about whether nurses were surreptitiously putting larger volume tubes in their pockets, which is sort of interesting. That didn't happen, by the way, not that we know of. In the proportion of insufficient samples, again, this was the major concern that we heard from people around the use of these tubes, was that there wouldn't be enough blood to be able to do all the tests that were needed. We assessed user acceptance in these focus groups, and we explored barriers and facilitators. And then finally, we tested our data collection methods. So I'm just showing an example of one of the posters that we developed for this study. And we actually ended up using these in the larger Stratus trial. So we individualized these for different sites. I should mention, people use different types of tubes at baseline. So we sort of individualize these. What we really wanted to do with our educational interventions, which was just to identify those key things that were going to be different with the lower volume blood collection tubes. They were the same they worked the same. They were from the same manufacturer. So it wasn't a fundamental change in practice with a new product. It was just that there were some slight differences, including the lower fill volume. And actually, there was a feel. The feel was a bit different, with the tubes perceived as being filled a bit slower. It wasn't slow enough to impair clinical practice, but just that the feel was a bit different. And what we found with our focus group discussions of nurses and lab techs was that really the user acceptance was quite high. Most people, you can see here from the quote, said it was pretty easy to incorporate into practices. There weren't really any issues. People noted that there weren't any barriers. They just had to get used to the visual cue of how much blood you need, not to throw those out because they thought maybe they were broken or misfunctioning. They thought that the education and training we provided was helpful. We did go into the ICU and into the labs. We did very brief in-servicing. We had a short video that we posted, and we just had a few PowerPoint slides again, and we actually took tubes and filled them with like red colored liquid to demonstrate the difference between the standard volume and the small volume tubes. So, again, we learned a lot of valuable information that we then were able to use to build a larger clinical trial that was definitive. So I'm just summarizing the results here for the sake of time, but we did implement the tubes. We implemented them by the research coordinator went into the ICU storage area, took out all the standard volume tubes, put in the lower volume tubes, and then put a new barcode. And essentially the new tubes were ordered using the same hospital practices by the same folks in ordering. So that actually wasn't as big of a challenge as we anticipated. It was acceptable to end users. We did not see an increase in the proportion of specimens that were reported as insufficient, which was really key. And we actually did estimate that we reduced the volume of blood that was collected by about 45%. So we deemed that a full-scale trial would be feasible, and we used the information that we obtained from this pilot study. And this was actually funded by an HHS New Investigator Fund Award to build the full-scale trial. So I'm going to switch gears now just to talk about the trial itself. And of course, I'm presenting on behalf of, you'll see at the end, there's a huge group of people who made this study happen. And I'm always happy to present on behalf of all of us these results. So our hypothesis for the full-scale trial was that transition to small volume or low vacuum blood collection tubes will reduce red blood cell transfusion in ICU patients. Here's the study design. So you've already seen that stepped wedge cluster trial diagram. So, hopefully people recall this was this is a study that took place between February 2019 and December of 2020. And as over time, you may also notice that in red, the COVID pandemic landed right in the middle of the trial, which was, obviously a huge issue, disappointment, challenge for us, like it was for many researchers and basically everybody around the world. And the stepped wedge design is particularly vulnerable to big changes as things go on. And we can talk a little bit about that at the end if people have questions. But essentially, sites transition to the intervention almost two at a time. In March of 2020, at the height or onset of the pandemic, we were just unable to transition the remaining 7 sites just due to issues in hospital and healthcare. So we had a hiatus where we stopped transitioning, but we continued to collect data throughout that time period. And all of the sites continue to use the same tubes that they were using or that they were allocated to at that time. And then in August of 2020, when things calmed down a bit, we were able to complete the transitions at those remaining 7 sites. So just to explain, and as we go through, you'll see why this is important. ICUs were eligible if they cared for adult patients. Medical surgical ICUs were included. So sort of we didn't include any very subspecialty type ICUs like CVICU or neurotrauma ICU or something. ICUs had to be large, so have 14 or more beds, invasive mechanical ventilation capacity. And we really, again, wanted to identify a high risk patient population. They had to be using standard volume tubes at baseline, and that was quite variable from site to site. We didn't pre-specify, that they had to all use the same tubes at baseline. That's sort of one of the pragmatic elements here. They also had to have data that were available electronically for data collection. And the way this worked was that all patients admitted to the ICU during that study period, February 2019 to December 2020, were registered. So data were collected on all those people. And this study was done under a waiver of individual participant consent, and that was REB approved. We only collected data electronically, administrative data that hospitals, routinely send to the Canadian Institutes of Health Information. So we just capitalized on information that was already being collected, transfusion data and lab data up to 30 days or until hospital discharge or death. Our intervention, again, was transitioning to small volume or low vacuum tubes. And you can see the standard volumes ranged from 4 to 6 milliliters and small volume from 1.8 to 3 milliliters. And these are the types of tubes we switched out. These are the tubes that are commonly used in the ICU, on a daily basis. So what's not included here is blood gases or blood cultures. We tried to reduce the volume of blood culture. We asked about that initially, but it was deemed not possible because of safety concerns and sensitivity of the blood culture collection media. So our primary outcome was the number of units transfused, of red blood cells transfused per patient during their ICU admission. And we had keys. These are just there. We had lots of secondary outcomes, but this is just a sort of the key ones. The proportion of specimens that were reported as insufficient for analysis. Again, the key major harm or concern about the use of these tubes. The proportion of patients who received a red cell transfusion. We looked at the change in hemoglobin from ICU admission to ICU discharge. And we looked at that a couple different ways, including adjusting it for red blood cell transfusions received. We looked at ICU and hospital length of stay and mortality in the ICU and in the hospital. So this slide summarizes some of the key features of our analysis. I think what's very important is that we limited our primary analysis to patients who were admitted to the ICU for 48 hours or longer. And we did this a priori because we wanted to enrich for a population that was, at high risk for critical illness, but also were the highest risk for transfusion and frequent lab tests. So, and we, again, the intervention depends upon repeated cumulative blood loss that affect anemia and transfusion. So, of course, it makes sense to focus on patients who are admitted for 48 hours or longer. After a lot of discussion and deliberation, we decided to exclude those patients who were admitted during that 5.5-month COVID hiatus. We were concerned, we didn't look at the data. We didn't have the data at the time. We made this decision in advance. But we were concerned that there was something not only so different about the patients who were admitted during that time, but also the care that they received, that we were concerned that there would be bias based on the systematic differences between those patients and the patients who were admitted during the other time periods. You'll see in a few slides why that was a challenge. for us, but in any case, that's what we did. I should also mention that we, in collaboration with our amazing statistical team at the PHRI, we did analysis and incorporated important pieces, the cluster trial design, et cetera, but we also included the duration of ICU stays and offset. So we accounted for that in the analysis, which is something that people often wonder about. So our key secondary analysis, of course, was all patients admitted to the ICU for 48 hours or longer, including the COVID hiatus patients. And then clearly the proportion of specimens which were insufficient for testing. So this summarizes just the flow through the study. 58 ICUs in Canada were assessed for eligibility. 3 of them already used small tubes. 2 said their practices weren't aligned, and then 30 declined participation. Mostly, we didn't get information from everybody about why they were going to decline, but based on our stakeholder discussions, this comes up a lot when folks ask questions. Based on our initial stakeholder discussions, there really was a concern about an impact on the lab. And so that was kind of the predominant theme that came out of a lot of our discussions. So I suspect many of those sites declined based on that. We included 25 ICUs across Canada, 14 in Quebec, 9 in Ontario, 1 in New Brunswick, and 1 in Manitoba. And in the entire study period, over 51,000 patients were registered. So again, every patient that was admitted to the ICU, we collected data on those folks. And in the end, 23,000 of those individuals stayed in the ICU for less than 48 hours. So our analysis population was 27,411 patients, of whom 21,000 were included in the primary analysis. We had 6,000 people who were admitted during that COVID hiatus. And so our key secondary analysis included, again, the 27,411. This slide summarizes just some selected baseline characteristics. Because of our pragmatic data collection methods, we didn't have a lot of information about baseline characteristics that people might like to see in intensive care unit, like illness severity scores and things like that. But I think you can get a sense here that these are fairly typical type of medical surgical ICU patients with mean age in the early 60s. 40% were female, and then we looked at ICD codes for most responsible diagnosis. There were some imbalances here defined as a standardized difference of greater than 0.1. And I'll just say that we did do sensitivity analysis, which incorporated these imbalanced baseline characteristics and didn't affect our results. So this is the sort of money slide. This is the slide that shows the proportion of units of red blood cells that were administered per patient per ICU stay. And in our cohort of patients, 30% of them, of people admitted for 48 hours or longer, received at least one red blood cell transfusion. And that's actually lower than what we had estimated for our sample size calculation, which was 40%. And even we thought at the time that was conservative. But as it turns out, we had fewer transfusions. And you can see here that in the primary analysis population, this is the excluding the folks admitted during the COVID hiatus. There was the difference in red blood cell transfusions after transitioning to the small volume tubes was not statistically different. However, in the larger secondary analysis population of 27,000 patients, we see that there was a difference, statistically significant difference in the number of red blood cell units that were transfused. I think it's easier here to look at the absolute mean difference just to help with some clinical relevance. What's also interesting is that both these estimates are similar in magnitude and direction, and we have one population, the primary analysis population, which was not statistically significant, whereas the secondary analysis population was nominally significant. Really important slide here too, showing that there were very few specimens with insufficient quantity in the overall in both cohorts, and there was no difference seen between the before and after transition to the smaller volume tube. So look, we're looking at 0.03% or fewer, which is reassuring. These data show the change in hemoglobin from ICU admission to ICU discharge. So it's a bit of have to wrap your brain around this one. So we looked at the change in hemoglobin, and what we saw overall from these results is that the change in hemoglobin was smaller after transitioning to the lower volume tube or small volume tubes in general. which is sort of consistent with the story that we're hoping we would be able to tell. So in conclusion, transition from standard to small volume blood collection tubes in the ICU may reduce red blood cell transfusions in patients admitted for 48 hours or longer. Although we didn't see a difference in the primary analysis, which excluded those 6,000 cohort COVID patients, we did observe a decrease of 10 red blood cell units per 100 patients in the larger secondary analysis population. We also showed that transitioning lessened the ICU-related reduction in hemoglobin, and these two sort of go hand in hand, right? So I think in total, these results suggest that there is an effect of transitioning to lower volume vacuum tubes and taking less blood. We also showed that there was not a negative impact on lab testing, but here, measured as specimen sufficiency. So I'll just end this section with some discussion that we implemented these tubes easily into clinical trial. We didn't measure that in the big scale trial, but we did look at that in the pilot trial. None of the sites stopped using the tubes, and many of the sites are still using the tubes, barring some supply chain issues. So we used very brief targeted interventions, which were completely scalable. We used pragmatic data collection, which is cost effective. We included both academic and community sites, which was a great effort for generalizability. And we show that, there may be a small impact at an individual level, but really here we have the potential for a larger impact at the health system level. Important limitations, and these are a few of the main ones, obviously the changes in the study conduct and the primary analysis due to COVID. Not sure we have to say much more about that. There was limited availability on baseline characteristics and co-interventions over time, just because of the nature of the data collection processes. We didn't standardize transfusion practices or waste practices, but we did encourage adherence to evidence-based guidelines and standard operating procedures at sites for both of those things. And we only really looked at one aspect of lab testing, which was deemed to be the most important based on our stakeholder engagement. So I just highlight here that among those 27,000 people who were in the ICU for 48 hours or longer, they received almost 36,000 units of red blood cells, in a little less than 2 years in 25 ICUs in Canada. So there's 10 times that number of ICUs in Canada. So if we were able to reduce transfusion by 10 red blood cell units per 100 patients, that means we would have saved 1,500 units just in this trial alone, just to give you a sense of the potential here for system change. And this is really important because we're now in a blood product shortage. This is just from a couple of weeks ago from the CBS website. You can go in and look at these updates all the time. They're posted there for you on the main page. And you can see very few, look, O positive, 1 day supply, A positive, 2 day supply. But even these ones, O negative, 3 day supply. This is a scarce resource. And we really need to be able to make sure that it's there for the folks who need it. And so I'll end this section with acknowledging the Stratus community, because I always say it takes a village to raise a study. And so this is my favorite little icon at the top where there's like a village of people who all contributed to the success of this study. The study team, and particularly Dr. Emily Bellecote, Stephen Hill, Shun Fu who, planned and ran the analysis, Dr. Stuart Connolly for his vision and support getting this done. And then the study team who are amazing. All of the leads at all the sites. And I should mention that in Hamilton, it was Dr. Emily Bellecote, Dr. Bram Washwerg, and Dr. Walid Al-Hazani and their team. So we're super grateful. Without any of these folks, it would not have been done. Just speaks to how important it is to have a great team. So this is to me like a call to action. Here you see where I stole that ICU vampirism, but now I've quoted it here. Or I've referenced it here. But people have been calling for this for a long time. These are some images just from the Choosing Wisely campaign over the years. I think it's time to move the needle on this problem. So I just wanted to end with the last few slides, maybe in like an inspirational way, just to speak to, folks who are embarking on their research careers. I started this at McMaster when I probably was an internal medicine resident, but maybe a first-year hematology resident. And we started out by, building this research program. We did a systematic review to summarize the evidence in this space. We did a chart review to understand how much blood is drawn and transfusions received from patients in the intensive care unit. We did that pilot study, and then we did the full-scale trial. So, this is like a testament to over 10 years of work and the support of a lot of people. And Stephen Hill and I always talk about how what Mark Crowther told me to go knock on Stephen's door. He's interested in this. And I knocked on Stephen's door like over 10 years ago. And we always talk about how that was such a fortuitous meeting. And so I've reflected a lot over the years on, some of the things that have led to this success. And to me, this is like a really cool part of the story too, which is that, it is really important to have a mentorship team. And a lot of times people talk about mentorship as, being one important person, but I actually think that you get it from so many different places. And it's important to seek out mentorship and to optimize the types of support that you can get from people, all around. And it doesn't have to be just people at your own institution. And in fact, sometimes having people on your team with outside perspectives is really beneficial. So the key ingredient number 2 is having a good research question. And this is always a challenge, like what makes a good research question? I like this FINER acronym, which is, feasible, interesting, novel, ethical, relevant. I think we're always in search of these like great research questions that are simple and compelling. But I do still like to think about this, and perhaps this dates back to being mentored by Professor Nancy Heddle in transfusion, who talks about this, the importance of developing a research question. But really, we did have a research question way back, and we just looked at different ways to address it and built over time. And then finally, I think like the most important thing is relationships with people, and you just have to keep in mind that your community is essential. And you cannot do research alone, and it's just very important to build your team and to appreciate your team. So I'll end here so that we have some time for discussion. I'm hoping that I conveyed to you today that anemia is common and important and modifiable complication of hospitalization, especially in ICU, and that it leads to red blood cell transfusion. That laboratory testing is a modifiable cause of blood loss that contributes to anemia and red blood cell transfusion, and we can contribute to this, and also we can help to mitigate it. And then that switching to the tubes that collect less blood for lab testing may reduce transfusion and reduce anemia in the ICU, in particular, without negatively impacting the lab. But I would argue that, patients outside of the ICU could also benefit, as, taking more blood from people than we actually need to do the tests does not add value to their care either and could cause harm. So I'll end there with some time for questions, I hope. And thanks again for this opportunity to present.
Thank you very much, Dr. Siegal. That's quite a tour de force and an amazing amount of accomplishments over the period of time, from inception of a great research question through to publication in the Journal of the American Medical Association. So kudos to you and that giant team or village who's worked alongside you. 25 ICUs across Canada is quite an impressive feat. And the number of patients that were involved in that study. I see you've muted yourself. I know your little doggies are causing a ruckus there.
So, the whole time I was like, "Don't bark."
So we've got a couple of questions. One in the chat, and 2 people who have hands raised or so on and so forth. So 2 people who will be asking the questions. First question in the Q&A is from Dr. Gerard Cox. Are criteria and practices for transfusing RBCs the same across the participating sites, or is there an opportunity to decrease transfusions by education around standards and practices?
Thanks so much for the question, Jerry. And nice to hear from you. And so good question. We didn't, so evidence-based transfusion practice in the intensive care unit is there are evidence-based guidelines. So we did encourage sites to use those evidence-based guidelines in their everyday practice. We actually didn't, as I mentioned, provide any guidance around, when to transfuse, for example. But I think you raise a good point about transfusion practices in general and education around, the roles that we play in ordering lab tests and reducing transfusion. I think for this study, we focused on this intervention, which is, although, it was relatively straightforward to implement. You can see that, it has still taken a while for people to adopt this. And so you can imagine what it's like to try to change physician practice in this space. So I think there's always an opportunity for education to ensure that we're transfusing appropriately, but it's a very big challenge that I think many people have been working on for many years. So if I had the answer to that, I think I'd be, very, very happy person. But
Yeah.
no, but certainly an important thing to keep in mind.
It strikes me that the so-called holy grail of decreasing transfusions might be the trifecta of decreased blood draws and then choosing wisely kind of principles of stewardship of testing, plus really trying to strictly apply the blood transfusion guidance. So very good point, Dr. Cox, and thanks for your response, Dr. Siegal. We've got a question from Dr. Gerstein, who I will invite to unmute.
Yeah, you can hear me, right?
We sure can.
Okay. Deb, that was outstanding and beautifully done, and a wonderful example for any young person who's thinking about embarking on a research career. I think beautifully presented, and the work is totally outstanding. And in terms of the findings, although you didn't quote formally test for it, it's clear based on the confidence interval that you've demonstrated non-inferiority of the new approach versus the old approach, which is great. And you have a number of suggestions that there may be, that there are some, and there may be some other findings that would be superior with a bigger size. But in the end, it's clear that there's lots of reasons to use less blood. My only question is, are you planning to, because I think you could demonstrate that very nicely, the benefits by a simple economic analysis of what you've done, the cost of the blood, the cost of transfusions, et cetera, et cetera. Presumably the tubes are the same cost. So are you planning to do an economic analysis? Because I think that would be kind of the icing on the cake of this wonderful cake that you've created.
Thank you so much, Dr. Gerstein. That's really kind from you. Appreciate that. What an accomplishment. We're pretty thrilled about the results, and I agree with you. There were some tricky interpretation things here, but overall, I think we see some results that I think here should inspire us to change, right? And you're right, the economic piece here is important to explore. We hadn't thought of it. I think it is really there aren't a lot of data, and other people may have more experience with this than me, but there aren't a lot of data about the economics around transfusion in Canada. So we know like the unit costs of transfusion, and Dr. Verhofstadt may actually know more about this too. The unit costs are known, the other costs are really not known, and often we're relying on other health contexts. So studies have been published from the US and the UK, which are quite different. But it is something that's worthwhile to explore. And I'm working with others, including Dr. Jeannie Callum, who's super keen on this topic and really getting the word out that maybe that's something that we could look at. I think there are challenges in terms of obtaining information, but maybe now that we have these results, it would be less challenging.
Just to add, you could, the ministries of health would be really interested in this information, and you could make approximations. But there are ways to do economic analyses that I think would be really relevant to all the payers. So anyways, that'd be just great. Thank you.
Cool. Thanks so much.
All right. And Dr. Greg Kernu also has hand raised with a question. So we'll invite him to unmute.
Thank you so much. Can you hear me?
Yep.
So to me, sometimes we use pediatric lipid, use pediatric size tubes for bloodlet. So should the standard be that everybody, what's the harm of using these smaller tubes on everybody? Should that become the new standard? And my second question is, anemia is complicated, and it's what to do and things of that nature. I'm interested in any pros that you have there. So just at the American Heart Meeting, there's a recent trial that looked at liberal transfusions, hemoglobin up to 100 versus more restrictive, and it showed actually a positive result. That more blood was better than less blood, and then all these patients have anemia for all sorts of reasons, and everybody ends up on iron therapy with more blood work. So how do we move this field forward a little bit better and be smarter about this? So I'd be curious what your thoughts on just using small tubes in everybody, and if I do in my chronic outpatient practice, especially in older, frail people, should I just ask for pediatric or small tubes for everybody? And how to be smarter about what to do about anemia in general?
Yeah, thank you so much. Good questions. And it's like lifetimes worth of work for many people. I think your first point, the first point I think is that yes, using lower volume blood collection tubes makes sense. We specifically chose the critical care patients with critical illness in the ICU as a population where we could demonstrate a benefit just because they're so frequently transfused and they have so much blood drawn. But again, I really think that we ought not to take more blood from people than we actually need. And if you actually tell people in the lay public that that's what we do. I mean, I've spoken to some journalists and they're shocked. They're like, what? You throw out my blood that you take and you take so much. So I think, really it's the onus is on us to really justify why we're doing that on an ongoing basis. Although I should say that there are likely to be implementation considerations. We really looked in the ICU. So, for example, many patients had central and arterial and venous access. And it was a different, so that's actually a difference, although some people had venipuncture as well, depending on some of the sites. So we didn't really track that. But so there will be differences in terms of blood collection technique, probably in hospitalized patients. So it wouldn't be one of those things where I would just say, okay, tomorrow, everybody should just switch over and that'll be that. Like, I think there's a lot more that needs to go into it. You really do need to make sure that the lab folks are on board. They do have concerns. They will want to make sure, I assume, because we've heard from them that their analyzers work, that there aren't going to be any problems in the lab. So all that stuff kind of has to be done even at the local level, probably before this is more widely implemented. But I should say that Jeannie Callum in Kingston, they just transitioned the entire hospital, including they started in the ICU, then they did the hospital, inpatients and outpatients. So it can be done. And we've kind of partnered up with a nice synergy of like trial and then real world, kind of routine practice stuff. So I think it can be done just with the right advocacy. And then the second part is, every little bit counts. Anemia is super complicated, right? And there's not one quick fix. And you saw that kind of diagram with all the different things that, that influence anemia, particularly in critically ill people who then can't, mount an appropriate response because their erythropoiesis is impaired. So I think little things over time, physician behavior is important to change, lab test ordering, judicious use of tests, reducing the volume of blood. It's kind of a multimodal approach. And so there are folks that work in this space. You may have heard of patient blood management, which is kind of an approach to optimizing hemoglobin. So I think, it would be nice for us to embrace these principles in our own space. But I agree, a challenging problem.
Thank you so much. So there's a couple of other questions in the Q&A. One from Dr. Graham Jones, which starts off, excellent, exclamation. Have you been able to identify a subgroup that does worse, explained by the magnitude of reduction in oxygen carrying capacity? Oh, we briefly lost Dr. Siegal to quiet down her dogs, I think.
I just kicked them out. Sorry.
I'm not sure if you heard that whole question.
Yeah. You know what? Again, these are great question. We have a database of 250 million data points. Like, it's pretty ridiculous. I don't think we were anticipating that type part of the study would occur. It's a lot of data that we've collected. So I think we're still going to plan to do some exploratory, post hoc analyses. We didn't have, again, unfortunately, granular data about the patients and their baseline characteristics and some other aspects of their care, just because it was admin database. But these are, I think, now questions that maybe can be asked and answered, perhaps if not by our data set, then by other types of studies.
Thank you. And the next question here from Dr. Ann Holbrook. Deb, so good to see all this come to fruition. Do you foresee a time where transdermal biometrics will be able to replace actual blood draws for lab testing?
Yeah, that's a good question. I don't know. Wasn't there that big scandal in the U.S. of Theranos and the woman who pretended that she could do that, or just with a poke? So I think like the combination, but the principle, I admittedly the principle is important. You also wonder a little bit about the power of AI to be able, and I am not somebody who knows much about AI, but I've heard some really inspiring talks lately. Not so much about like that would be able to change things, but certainly be able to identifying patterns of patients at risk and maybe those are the patients that you want to do more blood testing in. And there are patients who you can identify being lower risk, who you want to do less blood testing in. I think those efforts, it might be a bit pie in the sky to say that we wouldn't be able to ever need lab testing. And I think the challenge is it's very easy for us to just do testing. And so our behaviors is actually the hardest thing to change. I mean, even harder than changing tubes, obviously, which was hard enough. And we'll see now, we'll see if people implement. It's not easy to implement change, to see change through, right? So, but good point. But I wonder if there's a role in AI and predictions in trying to help us use, lab testing more judiciously in some ways, in addition to trying to reduce the volumes or of lab tests and how we do things and how we monitor.
Yeah. Thanks so much for the question there, Dr. Holbrook, and thanks for that response, Dr. Siegal. Lots of really fascinating things to come, right, as technology evolves in the lab testing space. I'm just catching up here on some questions and comments in the chat. So we'll start with one from, I believe this is from Dr. Karam Khan. Can this tool be used across hospital? What about other things like alerts to prevent repeat testing of labs that are normal?
Yeah, I remember my good friend and colleague, Chris Hillis, used to have a talk, and he showed, he did like a chart audit, and he showed that a person had 150 daily INRs that were normal in a row, right? So for sure, there's an opportunity to use technology to help with this. So yes, I do think that these tubes can be used across the hospital, but I also think that we need to be mindful of implementation and the importance of, you don't want to roll something out too prematurely and then it flop because you weren't quite prepared. It does require some investment of time and energy talking to the people who are actually going to be doing that work. And I don't know about you guys, but but man, epic alerts, alerts on EMRs are important, but it's really easy to just ignore them. And we get alert fatigue. So I don't know what the right answer is, probably some combination of things like that, but we often just click through those alerts, right, all the time. So I'm not sure that that's the answer, but certainly, being able to, notify people or have institutional practices where it's like an opt-in approach. You have to that there is no automatic blood work, that you actually have to make it. And I know often at St. Joe's they were doing that kind of work a while ago. Maybe they're still doing it, where in the ICU there was a daily goals kind of checklist, and part of that was, are we going to order blood work, and then what blood work do we need, as opposed to just it being on autopilot. So I think that's probably also a good approach. But yeah, these are challenging issues.
Thank you. I think there's several lovely congratulations and kudos from Dr. Corriveau, Dr. Cox, Dr. Woodward. I'll invite you to have a look there. And then we'll wrap things up with what looks like one last question from Dr. Christine Ashak. I've already noticed a move toward not doing daily blood work on the ward and changing to, say, 3 times per week or 2 times per week. Is there evidence around benefit of this and threshold for prompting the clinicians to implement less blood draws? I think this is, maybe you've just spoken to this, for example, via Epic at a specific threshold in the admission. You've become the blood testing conservation guru.
In my own life, I'm like, no, but it's just in one tube. I was like, I don't care. So you too can make this change. No, and there was that nice study that they did in Toronto that I referenced. I think it was Bogley was the first author. They did a QI, and it was in the ICU, but they actually, you can read that study. It was impressive. It was a lot of work, right? So I do think that's important. But also, even in my own clinic, we talk about, I do thrombosis clinic exclusively. We don't need to measure electrolytes in my clinic, right? Routinely. So if people want to order electrolytes, they have to justify what. Then I'm chasing down people to stop their hydrochlorothiazide and stuff. No. But, the point is that I think, being thoughtful about the tests that we're ordering and recognizing that, blood is a valuable, organ that we have, that patients have, that we need. And I'm not sure it shouldn't be squandered, right? Just for the sake of practicality.
Perfect. We'll leave it right on that quote because I
Okay.
think that's just perfect. Thank you so much to Dr. Deborah Siegal for returning virtually to us here in Hamilton and presenting about the amazing work that you and your colleagues have completed here. I'll highlight two other congratulatory comments that are in the chat and Q&A from Drs. Mazzotti and Patterson. So really a lot of tremendous feedback about the work you've done and the excellent, clear presentation you've given us today. For everyone who's joining us or who's joined us today, thank you so much. Citywide Medical Grand Rounds will be back next Thursday at 8 a.m. And we have a presentation hosted by HHS, which is part of our new recruit series, and it will be Dr. Catherine Woodman. So join us back next week and have an excellent day and rest of your week. Take care.
Bye. Thanks, everybody.